Okay, as we get ourselves organized, I'd like to introduce the moderator for the panel discussion is Dr. George Mexicano. George is well known to all of us who have been involved in this organization, CPE, as he's been involved for many, many years. George received his medical degree in 1990 from the University of Illinois. He's board certified in internal medicine and infectious diseases, which is kind of scary because that's the third time I've said infectious diseases today. So I don't know what's in the microbiology lab that tends to get to these people to want them to do medical education. But he also did a master's of adult and continuing education at the University of Wisconsin-Madison. Currently, he's the associate dean of continuing professional development and the director of the office of CPD at the University of Wisconsin School of Medicine and Public Health. And as I said earlier, he's a long-time CPE affiliation, and he's a really good question asker too. I've come to learn that over the years. So I'd like to introduce George to moderate this afternoon's panel discussion.
Thanks, Bill. Thanks a lot, Bill, and hopefully you enjoyed lunch and got a little bit of sun in San Diego. And Bill, the comment about infectious diseases goes something like this. You know, there's only three real problems in medicine. They're either congenital, traumatic, or infectious. So there you go. So imagine that, whatever you ate today. So with that, let me tell you how we're going to do this. I'm going to do some introductory comments. I'm going to ask each speaker to basically see if they want to say anything further based on the other comments that were made. So basically, give maybe 1 or 2 minutes of final thoughts, and then we're going to move into the meat of the session, which is really I'm going to pose it right now so you can start thinking about it, and that is, assuming we can actually measure professionalism accurately with validity, now what do we do about that at all different levels of the medical education continuum? The next thing I'd like to say is this. I'd like you to try to step out of your roles and really look at this from different perspectives. If you're naturally a person that views things from 30,000 feet, I'd like you to get down into the trenches. If you're a person that lives in the trenches, I'd like you to go up to 30,000 feet and try to alter your perspective. I think that may help you, and certainly some of the speakers have done that for me today. So with that as a very quick introduction, why don't we just go in a row here. Dr. Cruz, maybe you can start. Any further comments based upon what you've heard just about anything that you want to talk about right now?
2 comments. The reason why self-regulation is important, the sky won't fall, we'll all adapt if self-regulation is modified, isn't because, again, we, the medical profession, feel that it's important. Sociologists, when looking at regulation, have commented on the difficulties inherent in it. But it's interesting, Meg Stacey, when she was alive in the UK, Rosemary Stevens here, Fred Hafferty, the people who are outside judging us, I'm going to put my interpretation of their words in, feel that self-regulation means that goodness comes from within the medical profession. It isn't imposed from the outside, and they therefore have concluded that self-regulation, an independent and autonomous and self-regulating profession, is of benefit to society. And that external regulation is expensive, bureaucratic, and probably doesn't work as well as a regulatory process administered by the profession itself. So I guess that was a comment that I think needed to be made. It doesn't mean that we're going to maintain the kind of self-regulatory processes that we have had traditionally, and maybe we will have a majority of lay people on our governing bodies. Certainly that's been a movement everywhere. I guess the second comment I would make relates to the presentation this morning on teaching, which I very much enjoyed, but which I think that there are two aspects to teaching professionalism, and I really think they're both important. The first is that you've got to identify a cognitive base. We talked a little bit about it when we talked about evaluation, and you can use multiple choice questions to evaluate knowledge of what professionalism is. That's really important because if you look at surveys, lots of people, if you survey physicians, most of them don't understand the reasons for professional obligations. And it's something that we absolutely have to teach. We've got to identify a cognitive base, and then we've got to make sure that students learn that. And that's pretty simple. That's just like the crummy old Krebs cycle. You can evaluate that in a jillion ways. But then you have to take the values inherent in professionalism and healing, if you take our approach, and you've got to find some way of internalizing them, getting students to address these issues in semi-conflict situations that are safe, and incorporating those attitudes so that they will be expressed in behaviors. So, and I think that if I had been talking about teaching, those are the things, we do talk about teaching, those are the things we stress. So identify a common cognitive base that your whole institution agrees on, because you can't have different people teaching different things or evaluating different things, and then set up situations where students just can't avoid thinking about these issues and essentially practicing self-reflection on these issues in hopes of internalizing it. So those, I guess, are the comments that I would have made as a result of what I heard.
Thank you. Dr. Savoya?
So coming out of my mainly undergraduate medical education and graduate medical education role, I guess some of the provocative comments from this morning were how we can impact professionalism in the community of practicing physicians, as they are the ones that are really defining what professionalism is. And how to do that better, I think, is a real challenge. Isolation is a very big part of why people go wrong, I think, and that seems to be what PACE, Bill has shown us with a PACE program. And so reducing that isolation, figuring out how to provide time for reflection and opportunity for reflection in people in practice is something I think is going to be a challenge for us.
Thanks. Jill?
I would just like to build on that by going back to a comment that Dr. Cruz made very early this morning about AMA being the only representation for physicians in this country, and a lot of the problems that have come through the AMA. Without debating that, I would say one of the big problems facing organized medicine is that to a large extent, academia has been underrepresented in organized medicine. And so I would put out a ploy that if you don't like the way something is going, get involved and change it, because an organization that represents people is the result of that representation. It's the basis of democracies. It's the basis of how our country works. And there is a real, sincere, and desperate need for physicians like the individuals in this group who put so much thought and so much effort into making sure that we do maintain professionalism, to carrying that into the community and helping to bridge that base right there.
Thanks.
Thank you. It's interesting. I just sort of, as you provoked us to do, I wanted to sort of step back from my role as a regulator and say what I was provoked by is something that I'm provoked by often when a client brings me in. I do a lot of national campaigns. In fact, we did a campaign here on the uninsured and big challenge. This was a decade ago, before it was on the tip of everybody's tongue. And I was thinking, what would I do if we were doing a campaign about professionalism, and how would we try to inculcate this value at the earliest of levels? And when a client brings me in, they say, oftentimes I do a lot of work nationally on conservation issues. So we'll run focus groups, we'll do quantitative research, we'll find out what's on the public's mind. what are people thinking? And the client will always say, well, we want them to be like this or act like this or think like this or have these attitudes. And in this case, an attitude of professionalism or a behavior that says this meets a professional standard. And I always have to help them understand, if you don't first go to what we call the WIFM, anybody know what the WIFM is? What's in it for me? That you can spend lots of money, and I'm glad when they want to do that, right? To try to get people to do it the way you want them to do it. If you don't first address the WIFM, you're going to have a very expensive, time-consuming, frustrating experience. When you think about that medical student who's entering and you're inculcating them with knowledge and practice, you also want to think about, how do I sit in that seat where they're sitting right now and try to touch their head and their heart in a way that helps me to understand what they value. Someone said, it's going to Monday Night Football or whatever it may be, what they value and how professionalism will have a WIFM connected to them. What's in it for me as I sit here as a 21-year-old, 22-year-old, 25-year-old? Why should it matter to me that I should pay attention to this concept of professionalism, and how is that going to translate someday into my being, whatever it is that their values are? And I think if we remove ourselves from academia and regulation and the things that we typically do and ask, how can we sit in their seat and get at their values and what matters to them, and then start from there, rather than telling them from way up here, we know professionalism is important and here's why, because after 20 years of experience or 30 years of experience or whatever, because they're not going to go there. Like I always say to my clients, they're not going to come up to where you are. You have to go to where they are, where they're sitting in their seat, in that graduate program, in that medical school, and ask that question, what's in it for me? And I think as we can answer that, it helps provoke our thinking outside the box of different ways to build our approach.
Now, what I'd like to do from here is start the dialogue, and really the question is, so what? All right? Or what do we do about this? So let's suspend belief, and assume that we can actually measure professionalism accurately, with validity, in an ethical way. What do we do about that? Whether it's UME, GME, or CME, whether it's regulation, whether it's in your communities or in academia, so what kind of thing. And I'm going to start with a sort of a provocative question, and then we'll see where this goes. And it's going to be a little bit like herding cats. But some of you know that pay for performance is here. The idea is that we maybe ought to be compensated not for how much we do, but for how well we do it. So if we could measure professionalism well, could we envision compensating, rewarding physicians for being, quote, more professional or stellar in professionalism? Anybody want to take that question?
Actually, UCSD now has a new clinical initiative, a new strategic plan for its clinical mission, and it is clinical excellence through service, education, and innovation. And one of the components of that plan is actually to provide incentive pay to physicians, academic physicians, who have high patient satisfaction scores, and they're now determining a bunch of metrics that need to be met that would then lead to this incentive pay. So it's one academic medical center and I'm sure others are doing the same.
So I'm hearing 2 yeses. Any other panelists want to make a comment on that?
I don't want to be totally naive, so I'll say I question it. I won't come out as a definite no, but I have qualms about it because I think that the very nature of physicians doing things based on pay for performance in some situations is in conflict with professionalism. And the reason I say that is if you look at pay for performance as it has rolled out, and all systems are imperfect, it is imperfect because it can generally only compensate physicians for things that it can easily measure. And one of and so you have the debate that has been going on for probably 20 years now, since NCQA came out with its original HEDIS criteria that, gee, should a physician get more for ordering mammograms than the primary care physician that's doing a good history and physical and identifying a lump in the breast without the mammogram? And I think you get into professionalism. How do you really measure it in a way that the compensation can coincide with what you're trying to accomplish without breaking off that you're actually compensating for potentially for one piece of professionalism, possibly at the expense of another attribute? So I don't say no, but I think that it's a complex question that would need to be considered very carefully.
Fair enough. And Josie, I don't know if you've been sort of listening to this. Dr. Josie Williams in the back, but Josie is, I think, the incoming president of the Texas Medical Association, correct? As well as been a national leader around quality measures at the AMA. So Josie, maybe you could make a comment about this as well. It'd be interesting to hear your perspective if you want to. And so for the interest of the camera and those that are a little hard of hearing, basically, we have a long way to go, and we've got to make sure we're doing it right, but the measurement science and practice is getting better, and there's hope for the future. Any other comments from the panel before we open up to Q&A for the audience?
Just, could I make one comment?
Of course.
You know, there is a saying that goes, the perfect is the enemy of the good. And if we strive for perfection, sometimes we never even get to good. And maybe performance measures are somewhere in that informs that a little bit. But, you know, I just came, speaking of infectious disease, from the Infectious Disease Society meetings.
Here in San Diego a few days ago.
Which were. And there was a performance measure that was spoken about at great length, and that was delivering antibiotics to someone with pneumonia within 4 hours of their arriving in the ER. And what the unintended consequence of that performance measure was that people were getting wrong antibiotics, broad-spectrum antibiotics. The incidence of antibiotic resistance was up, C. difficile infections went up, and so we just have to be also very much aware of unintended consequences.
The environmental impact is important. Dr. Steve Miller from the American Board of Medical Specialties. Steve.
Questions I'd ask the panel.
Okay, for the cameras, let me repeat the question, Steve, if I can. The question is the first question is, should we achieve a level, or is really more of a broader picture across many, many different aspects of professionalism, correct?
Quality improvement. In other words, are you going to reward improvement or just achievement of a level?
So reward improvement as opposed to getting a certain level. You could even probably say the question of norm referencing versus criterion referencing would be another way of saying it. Let's take that question first, and then we'll get to the question about where comes the money.
How many of you have computers at home? You know, computers use. Okay. How many of you have IBM or PC-based types of computers? Now, all of those you who have Apple's computers stand. Because I know you're so proud of yourselves. Thank you. I just use as an analogy, and sometimes there's a risk in analogies because I don't in any way, shape, or form want to indicate that the practice of medicine is like the operation of a computer. We know, however, that our IBM-related computers, I have both. I have one that is an IBM PC, and I have an Apple, and of course I love the Apple, right? Because it always works, it always turns on, it always does what it needs to do. It does it within 10 seconds and 1/10 the time of an IBM PC. But we accept the crashing of the PC, and we accept all the exigencies of dealing with that PC. I think in answer to your question, we could and do need to promote broadly a standard that says this is the baseline of professionalism. These are the things that we should be thinking about when we operate in a practice, in a profession, whatever it may be. And that there are symbols, going back to the earlier question, there are symbols of that. You know, there's the Nobel Peace Prize. There's various types of ways of rewarding that aren't necessarily, though there's some financial tied into that. It's really about recognition. We started as a board, believe it or not, we're a regulatory board. We started a couple of years ago rewarding physicians who have achieved certain levels of accomplishment. And it's unusual. I think we're the only board in the country that does that because it's really not our core mission, but we felt that there needed to be a way to acknowledge, and these were certain types of societal or cultural achievements in terms of giving back. We could do the same thing with professionalism as a board and say, you know, there are people who meet this and exceed this standard. They're like the apples, right? They're constantly pushing the envelope on what it means to be professional. And they're a symbol and an image of that. We don't give a financial reward, of course, but there is reward and acknowledgement for that. Medical societies could do the same. There's nothing that stops them from doing that. Local newspapers, et cetera, could do the same. So I think you could incent and promote. I know your second question is about money. I think you could do that both singularly in terms of achievements as well as broadly by setting a standard. And again, not to make the comparison between an Apple and an IBM, but I think we all kind of get what that brand is about when we know that it performs consistently, reliably, regularly. It performs in a way that we are proud of, right? And we can say, that's my physician, So I think there are ways to do that, and that there are ways to do that and to make sort of those stellar examples as well as the general example of what professionalism is.
And anyone who has a Betamax, send them to sit it to Steve. Right? The guys all of you. Let's go to Frank first. The second question first. Where comes the money? Where should the money come from with regards to incentivizing this? Or maybe where doesn't it come from?
I would volunteer plastic surgeons.
Bill Norcross is volunteering plastic surgeons. Okay, I've seen the hands go up here. Saw Frank, then Bill, and then we'll go back to start working our way around. Okay, Frank, go ahead. You're first. So a pessimist perspective. Dr. Cruz, I think you want to respond. Maybe you can repeat the question for the camera.
A pessimist perspective, worried essentially, if I interpret this correctly, about those people whose behavior is very difficult to correct.
The people who came into medicine when it wasn't really necessary to be a good healer.
People who came into medicine when it was not necessary to be a healer.
On board, but
I guess.
When was that?
Yeah, I don't quite. I'm one of the older people here. I guess I'm not. There's some of us in that league, and I think one of the things that we've all been impressed with is the constancy of the motivation of first-year incoming medical students, their inherent idealism, their probably intuitive understanding of the role that they are expected to fulfill. And I think that the feeling has been that in some way we and the system managed to change them, rather than having people coming in not feeling that they're that's going to be an expectation. I've got some problems with this. The rubric of professionalism, as it is used, includes in general conversation the role of the healer and of the professional. We're sort of a little unique in that we split them out. But when you talk about medical professionalism, all of those attributes in both of those circles will be included. And when we say we're going to reward professionalism, you can't help but think that intuitively that's a very, very good thing. But whether it isn't the fact that it's that the tools are going to be difficult, it's the fact that it is so broad. It really is. You're going to reward virtue, and that's what Ed Pellegrino would certainly insist that we should be doing. And boy, that's going to be really hard. I think you're always going to end up rewarding things that you can, in fact, measure. And virtue is not going to be one of them. So I would be much happier not using the word professionalism, but using the terms that you can use, the terms of things that you can actually measure. I think that patient surveys can supply a substantial amount of information about caring and compassion and respect for autonomy and things like that. I don't think that's terribly hard to measure. But boy, there are other ones. Self-regulation, one of our major failings. How can you, your opportunities to self-regulate are not great. And how can you penalize somebody there? So I'd almost, I frankly don't object to pay for performance. I think that financial incentives and disincentives are enormously powerful levers for altering physician behavior. And I think that we should probably be using them, but I'm a little hesitant to use them in areas where I just don't think we've ever going to be able to truly measure that.
That's why I asked you to suspend belief and assume that we could. So, your point's well taken. Dr. Norcross?
Yeah. My understanding is that the United Kingdom has, for several years now, been involved with the mother of all pay-for-performance programs, putting an extra $1 billion into the system.
Payment by results, you mean? PBR.
Yes.
Yeah, whatever you call it, but it's been huge. It hasn't just been a little bit of money. It's transformed practices. In the highest cases, it's doubled the income of GPs. So it's a big thing, and you must have some data by now. So one question would be, what's your sense of how effective that's been globally? Second, I know there were something like 200 and some quality measures that were measured. I wondered if any of those had to do with issues of professionalism. And then third, where did that money come from?
So for the camera and for those of that, a little bit of introduction, the question or the postulate is, in the UK, they've been experimenting with this. So what have we learned from that? And who Dr. Norcross is going across the room having a discussion with is Alistair Scotland from the NCAS, the National Clinical Assessment Service from the United Kingdom. Alistair?
Basically, I think what was very important and a very interesting insight was what Dr. Cruz said this morning about the way the medical profession responded when the new contract was being negotiated. We had two different contracts negotiated at that point. There was the hospital doctor's contract and there was the general practitioner's contract. They're very different. One is an employment contract, the other one is a contract for provision of service. Now, I think your analysis is spot on, and that was where the problem really occurred. Because in practice, the very short answer to your question is that there is a massive row going on in the United Kingdom at the moment about the fact that there's essentially been a huge increase in salary with absolutely no return on investment. What happened was that the elements of the contract that were rejected, well, I think the analysis was quite correct. It was about what do we actually do in exchange for that? How do we behave as individuals? And what has happened is that GPs are earning huge amounts more money than they were. It is variable across the country, but the highest earning GPs are the highest earning doctors in the United Kingdom now, and £250,000 a year is frequent. It's not universal by any means, but it's frequent. But the row is, it's all for no return. And my human resources colleagues criticised the way it was done, because when the contract was rejected, they just threw money at it. So what they said was, okay, well, you don't want to give us that in exchange for the money. How about we give you the money and we don't ask you to give us it back? So there isn't an answer that says we've learned a great deal. There is an answer that tells us that there are very bad ways of negotiating with professions, and one of them is to throw money at it.
Thanks, Alistair. And for those of you that are more interested, there's a whole bunch of literature up here from the NCAS. We heard a great deal from at our earlier meeting this week. Let's go to Percy and then over to the same table. Percy, Dr. Galimbardi from Texas A&M.
Yeah, I have a comment on this. I think it is a very tricky question whether or not rewarding professionalism, because we have to still getting agreement about the definition. It's very tricky. But what I can see is that professionalism has a lot of qualities that are a must in the medical practice. So rewarding this from a physician practice or to a physician who is practicing with professionalism seems to me similar to rewarding somebody for stopping the car in the stop sign in the street. You know, it's something like that. I think professionalism is a must. It's a must. I think we have to come up with some ways to measure it well, to define it better, to measure it well throughout the whole career of the students, residents, and physicians in order to make sure that everyone is practicing with the highest level of professionalism.
So an expectation, not something to be rewarded. Let's go over here to the...
I think the pragmatic answer to the dollar question is that if you look if you consider first that more than 60% of the insurance dollars come from state and federal budgets. That's number one. And then number two, if you look at the direction that CMS is headed in terms of what it's going to do with hospital reimbursement based upon a new way of assigning severity and present on admission criteria and things like that, that the reward for some will come out of the previous payments of others. And that's the way the federal government and the state governments are going to have to go, because they're not going to expand, they're not going to do what was done in Great Britain. They're not going to expand the budget to meet our needs so that we can do what we should have been doing all along.
And so a part of question, an answer to Steve's earlier question about maybe a zero-sum game in terms of the dollars. Any comments from the panel before we go over to our friends from Ireland?
Well, I'll just say that certainly in somebody who's worked essentially in a state-run system, that's absolutely correct, that they work on a budgetary envelope, and things have to be done within that envelope, and it's very rare. Now, the UK was unique in that they were spending 6.5% of their GDP when the OECD average was 8.5%, and the Blair government committed itself to reaching the OECD average and essentially put 2% of their GDP into healthcare in a very brief period of time. So they had, we mustn't think that we'll get extra goodies from governments in North America.
Yeah, in Ireland, we've had huge battles with the government to get hospital consultants well paid. On the table at the moment is a basic for a hospital-based specialist cardiologist. Anything else, €216,000 as the basic. The big argument is how do you incentivize above that better performance? And you've got to be very careful, because you undermine your professionalism if you start looking for tips. If I give you good service and I smile and I behave as a nice person to you when you come into my rooms, I should get a tip from the patient. That's what you're looking for. You want to be reimbursed for being professional. And if you talk to somebody from an outside agency and looking at doctors and say, get real. Your professionalism means you behave properly as a given. You don't ask the pilot to smile at you and land properly. You expect it. And you don't give him a tip when you get off the plane out of relief.
Thank you for the comment. Let's go way in the back, but I don't want this conversation to hinge on this issue of incentives. So if you start bringing more themes, then that'd be terrific. Let's go way in the back.
Just at the risk to take slight issue with that, I think we assume competency. We assume the plane's going to get where it's going. We assume the doc's going to do the right thing. So the only way they can differentiate us now is on service. I mean, it's not exactly the same as professionalism, but it's one of the things people look at. And I don't think that businesses other than medicine would think, they wouldn't say get real, they would say, no, you have to have good service. And we've said that it's an expectation that you're going to smile and do all the right things. But we all know it doesn't happen all the time. So what do we do?
We have at least two comments from the panel. Let's go first with Jill, and then we'll go over to Dr. Cruz.
I just have to respond to that again from the real world. I don't think that we assume that the competencies are equal among all physicians, and I wish it were so, but I think that the profession has a way to go to assuring that standard level of care is universally met as a starting point. So I don't think that's an assumption we can work from, but I think we also heard this morning that competency was a component of professionalism. So that gets into the issue of how do you define professionalism and what are you reimbursing for?
Great. Dr. Cruz, and then we'll go up here.
Frankly, I haven't thought about this very much because it's certainly not an issue in Canada. But I think philosophically I'd be a lot happier penalizing people who fail to demonstrate professionalism than I would be reimbursing people who are being professional, which is what sort of goes with the job description. And I think that penalizing people is possible. And it saves money.
All right, hold on. It's like herding cats here. All right, let's go here, and then we'll go to Steve in the middle.
I'd like to speak to both incentives and to measurement, and I think probably a lot of people are familiar with the social science research that cautions us that sometimes when you put external rewards into the system, the internal rewards start to disappear. Listening to Dr. Savoya, it sounds like they're doing so little reward that that might not actually happen. And what might happen instead might be more like what happened in the VA system. I happen to be a surgeon with the National Surgical Quality Improvement Project, when all of a sudden we were all getting very good data continually, and the whole system, whole country, the outcomes moved in the right direction.
So the idea of a rising tide raises all boats.
It's all boats.
Yeah,
So if
exactly.
the institution is giving 2 awards, that's not the important part. The important part is probably that it's getting the data and people are acting on it.
So, and I think the whole idea of feedback that I blanked out that Steve talked about would get to that. Do you want to respond, Dr. Savoya?
Well, I think that part of the issue, the devil is always in the details in terms of how you roll out any kind of a program. But what and there are 2 value systems, again, that all of us ought to be professional, and then we're rewarding professionalism. How does that all play out? But I think that it is important, looking at the current role models that people have of doctors and what people are thinking of doctors, that we believe that it's important, that we say that it's important, that it becomes a cultural norm, and that it is rewarded. We cannot only just punish. I think, again, you have to have the whole thing in place, or I don't think it plays out. Now, again, that doesn't mean that there are not going to be problems and there are not going to be issues, and the rewards shouldn't be big. I would love to come and make 216,000 euros in Ireland, I think, or, yeah. I mean, that pay here in America now is, that for primary care kinds of people, that's a lot of money. It's an awful lot of money. For deans, it's a really awful lot of money. But, so I think that the whole idea of, again, people coming into a group whose attitudes are not held terribly strongly, being influenced by the major attitude of the group, and having that articulated very clearly as the major attitude of the group. It's clearly what's in this room, but I'm not so sure it's out there to the same degree that it is. And so this is one way of saying, yes, we believe that quality is important and professionalism is important.
Let's go with Steve Barron and then Alistair, but let's try to get off the incentive question. I think there's other issues here.
If we're off the incentive issue, then move on.
Okay, Alistair.
Yeah, well, I was actually going to try and get us off the incentive
Okay,
issue,
excellent.
come at it from a different direction. Really, it was taking up the point you made this morning, which I was very struck by trying to get away from the notion of good feedback, bad feedback. And the thing that I thought tied very neatly into what you said about really making sure we were in the middle. Because I think what you were saying will only work if you're sitting in the middle, i.e. that you're not tactless and you're not actually dishonest or flattering and so on. And I was trying to think, and I'm really throwing it back, how could we use a risk-based approach to regulation around professionalism and tying it into the way people develop their careers and their education? We were exercising ourselves at IPAC, the international group, and a paper that Ian St. George from New Zealand presented really looked at a number of things that were seen as risk factors for failure, and they fell broadly into 3 groups. A sort of professional group, which included things like the behaviours and so forth. A demographic group, which were about things that in the UK it's now illegal to say, so I'm safe where I'm standing now, like ageing, and itinerance, gender, and so forth. And then a competency group, which includes things like performance indicators and so forth. Really, I'm throwing a question back. Instead of looking at incentives, can we actually take a risk-based approach to regulation, which might incorporate that? You start to see some risk factors appear. You have almost like a Glasgow coma scale quotient that makes you come back quicker for relicensure.
Panelists?
How many of you wear seatbelts? How many of you know who the main deterrent, the single person who did everything within his power to resist the advent of safety measures like seatbelts and airbags in the automotive industry? Who was he by name? I give it away, it's a guy. Lee Iacocca. And guess what? He was the ad spokesperson when he was running Chrysler, I think, at the time, right? Saying safety, 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 safety. Why? They found out safety sells, right? They found out that as you said, the potential risks to my family, to myself, to my body, to my vehicle, to somebody else, et cetera, were so great by data that could prove that all of a sudden now, for the most part, I would say people wear seatbelts. And as you know, cars are manufactured now not just with one airbag, not just with two airbags, not just with 6 airbags, but my car, I think, has 8 airbags. I think it floats when it goes down the road because there's so much air in it. So I think your point is well taken. I go back to my old psychotherapy days that, as was said earlier, you can punish bad behavior, you can ignore behavior, which is mostly what we're doing, I think, with professionalism. We sort of ignore the conversation, except for today, and what you're provoking. And then we reward good behavior. And we know from all of the studies that no matter what you do to punish bad behavior, it's never as effective as rewarding good behavior. I think it's a balance of both of those, and I think we miss the point when we ignore it. When we say, and I heard you say, suspend judgment for a moment and pretend we can define and measure professionalism. Right? So I've been trying to do that, right? So I'm assuming we can define it, and I'm assuming we can measure it, and then the next step is to assess it, and then I would say acknowledge that which is good, and acknowledge it in ways that aren't necessarily financial, like I said, because I think that does substitute a whole different system. But we know who's caring and who's loving, and we think of a Mother Teresa when we think of a selfless person and such. How much was she paid? Right? And we also know, and I think this is true, and this is what I found in all the work I've done in the years I've been on this board, I've never met a physician or a physician group or spoken to a hospital or a group of specialists that hasn't agreed with me that we all want the good practice of medicine, right? We all want the good. Patients want that, society wants that, and physicians want that. So I think there is a way to define and measure and then acknowledge that which is good. And we have to, unfortunately, punish, like I said, that narrow piece that falls below the standard. Right? But let's not ignore when someone does meet the standard. And most of all, I would say we should and could acknowledge, and I know it's a little bit back to the incentive, but in response to your comment, we are a risk-aversive population. We are a risk-aversive species. And we know there's risk involved in litigation, right? Loss of practice, loss of license, those sorts of things. And if that was more commonly understood, like I said when I spoke to Rusty's class and I came out, and I know they wanted to get their degree and their license and such, I wanted them to understand that there are some risk behaviors that you could engage in by which you would come to our attention. Don't ever do that, right? And I think that can start not only, like I said before, in med school, but beyond, right? Through case study and education and opportunity to help people learn, gee, my unprofessionalism or even questioning certain things can lead to high levels of exposure and risk. Ergo, I need to find different ways of doing this and speak openly with my colleagues about how they do that. So.
Thanks. Dr. Cruz?
You know, it's interesting putting it that way, and I think it certainly is possible. You know, I've mentioned earlier Maxine Papadakis's work. I mean, that is extraordinarily powerful, and she's got unpublished data, which we hope will be published, linking certain behaviors with certain very specific type of aberrant behaviors in practice. Essentially, we've got the beginnings of a database that can identify the high-risk individuals. So I would have thought that we're partway there already. There's some, her work and other individuals have shown, for example, that being on time and meeting obligations within undergraduate medical school is associated with subsequent unprofessional behavior in practice. I mean, we know that now that we can predict, not that everybody who demonstrates these, but that a greater than the norm will. So I think that that's where we're going to end up. We're pretty close to being able to do it now.
Let me ask the audience sort of a show of hands. I have a question for Rich Hawkins here in a second. Who believes that physicians can self-assess their own professionalism? Let's see the hands. Who can do it? Who believes it should be some sort of third party?
That's a different question.
Okay, all right. All right, who, and let me split the questions up then. All right, then, so a couple of people raised their hand in terms of who believes that docs can do it themselves, who believes they cannot do themselves. Let's see the hands. So the vast majority of the people voting, at least, said that. The next question is, should third parties do the assessment? And it calls to mind a paper that Mark Albanese and I and several other people wrote about when students come out of a test and you ask them, did you do well or not, and how to correlate it with the actual test results. And what we uniformly found was that the students that felt confident that they did well didn't do well, and the students that often felt they did not do well did quite well. So I saw Howie Zeitz from the University of Illinois first, then we'll go back to the back, and then Steve.
Long ago and far away at Rush University, we actually had a group of students who we taught how to self-assess. Part of that teaching was they actually practiced doing it on a weekly basis, their work of the week, midterm, for the purpose of talking primarily about setting goals for the rest of the term, and end of term is a summative assessment. They self-assessed, they received peer assessments. We actually taught the students how to do peer assessment. And then they got a chance to practice that over and over and over and over.
Around professionalism.
Not necessarily around professionalism, just around self-assessment.
In general.
Broadly speaking. It could be about whatever kind of feedback they wanted to give them that week. It wasn't good or bad, it was feedback about something. Each individual thought about, the students worked in groups of 6, so there were 5 peer feedbacks to you every week. There was peer feedback to you summative at the end of the term. Midterm, just the student did their individual feedback as they had been doing week by week. They also got the faculty feedback, midterm and end of term.
So if I could,
They became very good at it.
so if I could summarize, the experience at Rush in Chicago was that it could actually be taught and they could do it well.
Yes, and the other part of that experience, which is pertinent to this discussion, is that the students who did not do good at it, the students who were unsuccessful at developing that, we had to form a breakfast club to give them special trainings to try to overcome their inability to do it in their regular setting that was working for the other students.
So potential flag. Let's go all the way in the back and then up to Steve.
Yeah, it was just an echoing point that if we give up on the ability of being able to successfully self-assessment, we may as well pack it up and go home. Because the number of times you have to self-assess yourself in the ongoing act of delivering health care is daily, and the number of times we're going to get assessed by a professional body or a peer professional, it's going to be far fewer. So I think that making a general conclusion based on studies of asking students how they did on a test is really quite limited.
No, I agree. I'm trying just to stir the pot here. I'm a provocateur. Steve, and then we'll go over to Rob.
Just to try to correct the notion, which I think has been, people have taken Dave Davis and shortened what he said, when in fact there's nothing wrong with self-assessment that's done in a formative manner. There are individuals who we should be discussing now who could never do that, Rusty, and they failed professionalism, and they shouldn't be here. There are others of us who don't really want to see all of the warts, but could say in this particular case, I might have done better if I did X or Y. That's formative. That's very different than summative self-assessment, and that was the problem when Davis looked at it, and Eva and that group.
That's a good point, and we're going to get into that in the roundtable discussion in just a few minutes. And if Dave Davis was here, he shows a great slide that basically says, I didn't say exactly that. So your point's well taken. Let's go to the comment over here, and then we'll come back to the panel to see if they have responses. Go ahead.
I guess I want to bring a little bit more of a psychological perspective on this too. I think self-assessment is really important, but there are 2 really important skill sets that you have to have in order to be accurate self-assessment. One is self-awareness, and the other one is the capacity to reflect. And part of what I've seen in all people, but particularly physicians I've worked with in remediation, is they don't have that skill set. And so to ask them to accurately self-assess, and what we're really talking about here, nobody here today has said the words or used the term, but we're talking about a level of emotional intelligence that I think is not taught, and it's a critical piece of professionalism. And we can't expect anybody to be able to self-assess if they don't have those other 2 important skill sets. So how do we teach students or physicians how to reflect? And self-awareness is very important. So,
Panelists?
I think our standardized patient program actually is, and using standardized patients is, and then having students who don't do well actually look at their tapes, do some self-reflection, work with a faculty member around those issues, is one way we found where people have had major problems with communication coming out of that in a very positive way. The other point I wanted to make was the Brinkman paper that I talked to you about with the randomized control trial had in the group that improved, they first did self-assessment, then got the evaluations and met with a facilitator to talk about the differences between their own self-assessment and the nurses' evaluations of them. And that, I think, it's hard to know what variable exactly was the power, but certainly the combination was very powerful in that study.
Dr. Cruz?
Yeah, I think that we have to put this into the context of the use to which this assessment is going to be used. Bad sentence, but you get the gist. We've got a responsibility to society, and that responsibility really begins in medical school and through residency and then in practice. And certainly self-assessment is not sufficient to meet our obligations to society. It probably has a place if it can be carried out, but it isn't enough to protect the public. And so I think you can talk about self-assessment as a formative tool and so forth and so on almost as a teaching tool, but not to protect society.
Dr. Pearson from Columbia.
We have come a country mile today in understanding professionalism. I feel like the six blind men and the elephant walking around and seeing different things and defining it different ways. It's been terrific. It's been wonderful. It's been mind-opening. A piece that this organization exists for is not just to define what professionalism is. It's to say, hey, there's some people who haven't done well. And is professionalism one of the aspects of the cure, the remediation, the enhancement, which is going to make a difference? And I hope that having blind-minded the elephant to a certain point, that we'll have a few minutes left over to talk about the pieces of professionalism which are useful for those who are going to do the remediating, and just how that's going to fit into the formula. We haven't talked much about that this afternoon.
That's a good segue to the roundtables, which we're going to break up into what I'll call areas of focus, UME, GME, and let's say physicians in practice. So Dick, if you could, perhaps we can wait just a little bit for that one. Let me ask my last question, because we're almost at the end of the hour, and for Dr. Cruz, let me throw a little bit of a challenge to you. Martha Illich and I were talking about the younger generations coming up, and there's some fabulous books, including one called Generation Me, where there's basically a number of young people who, they got medals just for showing up at the soccer game. They were told, we love you for who you are, not for what you do. They have a sense of entitlement without much experience in responding to feedback. What would you say to that younger generation? What words of wisdom do you have for us, if any?
Well, it's an educational issue, isn't it? You can only hit the balls that get pitched to you, and essentially what gets pitched to us is that current generation who are entering medical school. We can't change them. They come out of society, and they're going to go back into that same society. And I think that the value system of society has changed. If you talk to people who are running major law firms, another profession, they will tell you that lifestyle issues are driving them crazy, that they can no longer force people for the first 3 or 4 years out of law school to work several hundred hours a week, that for some reason they don't like it anymore, and they're rebelling. So that this is a way of life. But what do we say to them? They have to understand the patient's expectations. They have to understand the consequences, not just to them, but for the medical profession. If the public no longer feels that we as a profession are there for them when they need us, when an individual patient no longer feels that doctor is going to put their interests first. It doesn't mean working 7 days a week and 24 hours a day. But the principle is absolutely non-negotiable. And we don't have any outcome measurements. We've been teaching professionalism in a very structured way at McGill for quite a while now, and we do know that our students understand the vocabulary, that they understand the issues, that they've thought through the issues. It's going to take 15 or 20 years and doing what Maxine did and looking at outcomes in terms of patient satisfaction, complaints, and physician satisfaction, because we kind of think that people are proud of being physicians, and if they lose that pride, that the profession is going to be changed, and that being proud has something to do with sort of an ethos of service. It's a long answer, but I think that you can hold a rational discussion with these the newer generation. You have to do it first by telling them what professionalism is, discussing the implications of major changes in the social contract, and then letting them talk and work it out by themselves.
I'd like to thank all of our panelists for not only their presentations, their thoughtfulness, but for responding to my, well, just my usual being a pain in the neck. Bill's going to come up and tell us what the next thing is, but I will close with my last comment, and that is this: what we can measure, we can improve. So I'm an optimist.